Hi, everyone. Thank you so much for tuning in. And it was really great to be able to see where some of you have traveled to. We've got a very well-traveled group here. My name is Hannah Evans, and I am the communications manager at Population Connection, and I'm going to be moderating the talk today. We're really excited to have you guys here with us. This is the final day of the summer speaker series, and we have two very special guest speakers today with us. So today we have two speakers from Wings Guatemala, which is an organization that provides direct healthcare services with a focus in reproductive healthcare throughout rural and urban communities in Guatemala. They also do a lot of education and outreach and youth engagement and things that they're probably going to explain in a lot more depth during the presentation. But Wings is an organization that Population Connection actually partners with. So because of this, I was actually able to travel to Guatemala for over the course of a week this past January and was just so impressed by the amazing and super impactful work being done by this organization and also by the passionate and sort of capable staff. So I'm really, really honored to be moderating this talk today. Thanks again so much for joining in. And so I'm going to take a few minutes to introduce the speakers. After I do that, I'm going to turn it over to them for the remainder of the presentation. And then after, I'm going to facilitate a Q&A. So if you've already submitted questions, great. And if you have questions that you'd like answered throughout the presentation, please feel free to use the chat box to do so, and I will facilitate the questions after the presentation. Okay, so our first speaker is Dr. Rodrigo Barillas. He is the Executive Director of Wings, and he's been that since November 2014. So Rodrigo served on Wings' board of directors from 2011 to 2014, becoming president of its then Guatemalan subsidiary, Alas. So he brings over 15 years of experience working in both private and public health sectors in Guatemala and throughout the United States. Rodrigo holds an MD degree from the Universidad de San Carlos de Guatemala and an MBA degree from the Universidad Complutense de Madrid. He completed a fellowship in research at the Children's Hospital of Boston and Harvard Medical School, and a postgraduate degree in healthcare management. Rodrigo has over 12 years of experience in nonprofit boards. He has served on the boards of the Rotary Club of Guatemala de la Ermita, the Guatemalan National Cancer League, Wings Guatemala, and Ceres Global. He currently serves on the board of directors for Population Connection, for us, in the United States, and the Antigua International School in Guatemala. Rodrigo is proud to be raising two feminist sons with his wife, and we couldn't be prouder either. Thank you, Rodrigo. Our second speaker is Dr. Michelle Dubón. And she's the medical director for Wings Guatemala. So since 2015, Dr. Dubón has overseen all technical aspects of clinical services provided by Wings. She has been in practice since 2004 and has specialized in OB/GYN services since 2008. Michelle received her medical degree from Universidad de San Carlos de Guatemala, and she is committed to providing the highest level of reproductive health care to all her patients and is very well known for a gentle bedside manner. Michelle was part of the 2019 class of Aspen Institute New Voices Fellowship, which is a group of 25 leaders from the Global South who work on the front lines of global development and health. As a trained ballerina and talented singer, she brings grace and creativity to her work at Wings, often singing to her patients as she performs surgeries. So again, we're very excited to have both speakers, and I can't wait for you to learn more about this wonderful organization. So without further ado, I'm going to turn it over to Rodrigo.
Thank you, Hannah. Hi, everyone. Thank you so much for being here, and good afternoon. This is really exciting. This is only the second time that I do a Zoom conference, and you know, fingers crossed, everything is going to work out just right. So, you know, if anything happens, please bear with us. Thank you all so much for your attendance and your interest in learning about Wings in Guatemala. We are really happy to be here. I do want to begin by expressing my deep honor in being a member of the Board of Directors Population Connection. I also want to give many thanks to everyone on the team that's making this presentation possible. Marianne, Hannah, Rose, and anyone else that I may be forgetting, thank you so much. This is really, truly great. And both Michelle and I are very excited. Michelle and I have divided our presentation into 3 sections. First, we'll begin with a short, hopefully it'll work, 5-minute video that will give you an idea of what we do each and every day at Wings. Secondly, we'll give a brief presentation about some critical socioeconomic indicators, our reach and our impact, that we hope will give you a better understanding of the conditions in which most of Guatemalans live. And lastly, Michelle will talk to you about the specifics of our work and our programs, both before and during COVID. Then, as Hannah mentioned, we'll have a Q&A. If you have sent your questions, thank you so much. But if you haven't, please send them in the chat box. So here we go. Let's get started, and let's hope that the video runs well. Give me one.
Guatemala es el segundo país con la tasa más alta de mortalidad materna, superada únicamente por Haití. La tasa de fecundidad en el área rural, en el cual se incrementa a 3.7 niños por cada mujer. Las mujeres comprendidas entre 15 y 19 años, de las cuales un cuarto en el área rural ha estado por lo menos una vez en su vida embarazada. Pues estas pacientes no tienen acceso a servicios y para poder acudir al servicio tienen que conseguir dinero para el transporte, conseguir el permiso del esposo para poderse trasladar. El objetivo fundamental de la clínica móvil es llevar el servicio de salud sexual y reproductiva específicamente a aquella mujer en el lugar más recógnito, más alejado de la sociedad y del sistema de salud, poderle otorgar el derecho a recibir esa información y ese servicio.
El otro objetivo de la clínica móvil es también llevar orientación para que tomen una buena decisión en la elección de su método. La mayoría de las mujeres desean darle lo mejor a sus familias, pero el problema más común que vemos son los mitos y la desinformación que tienen las mujeres en relación a los métodos.
Se le va a colocar anestesia, en un aparatito se le van a colocar los implantes así. Lo único es que como el implante está negativa, vuelve a hacerse en 3 años, ¿verdad? Y flujo con mal olor.
Los problemas más comunes creo que ha sido la cantidad de hijos. Eso ha sido un problema que afecta también la salud de ellas y la economía, y al brindarles un método de planificación familiar ellas pueden decidir, ellas pueden darle una mejor calidad de vida y principalmente en sus hijos, que es en quien ellas más piensan.
los hombres quieren, sus esposos pues quieren que tengan sus hijos, bastantes. Entonces el hombre aquí es muy machista, la religión también, pero no es así, porque ya el hombre ya no tiene trabajo, ya no tiene cómo mantener a los niños. Pero ahorita ya la mujer como que ya despertó. Ahorita la mujer ya se defiende, aunque no quieran, ellos lo hacen, se ponen su implante o planifican, ya no quieren más hijos.
Una mujer tenía 20 hijos y nunca había hecho su examen y nunca había utilizado tampoco un método de planificación familiar, y el llevar este servicio tan lejos a personas que nunca han tenido este acceso, creo que marca la vida de nosotros a querer seguir haciéndolo.
Every time I watch that video, I still get emotional. You know, our team, they're the heroes of our story, and we're just happy and honored to be the messengers. But they're the ones out there, and they're certainly the ones out there now during this pandemic. You know, we're in a way comfortable in our desk and safe in our office, but they're out there. So if you want to send them all the energy that you can, please, we will appreciate that. But let's keep going. As I mentioned, we're gonna show you some statistics, some socioeconomic indicators. What you'll see is our institutional presentation. I'm gonna skip through some of the slides. I'm gonna show you the whole presentation. But I hope that what I do show you will give you an idea of how most Guatemalans live. So let me share my screen once again. Okay. So our mission is to provide quality reproductive health education and services to underserved primarily rural Guatemalan youth, women, and men. Now, the video that you just saw, that's what a typical day for our mobile unit teams or the satellite teams look like. They go out to the communities very early in the morning. They don't often come back the same day. Sometimes they stay out in the communities and come back, you know, a couple days later. But this is really what we're doing. 92% of our patients, of the people that we serve, live in rural communities. And we do envision a future where all Guatemalans thrive and are able to fully exercise their sexually reproductive rights. So some of you may be asking, so why Guatemala? So you know, the average Guatemalan woman is pregnant for more than 1,000 days during her lifetime. 1 in 3 indigenous women have no access to reproductive health services. Depending on the statistic, anywhere between 75% and 80% of the indigenous population lives in poverty. Nearly 50% of children under 5 are chronically malnourished. And Guatemalan women have on average 3.1 children with 3.7 indigenous communities. But of course, this is the tyranny of the averages. Guatemala City, which is a very urban population, the average there is 1.8. In some of the communities that we go to in the highlands, that number can go all the way up to 4.1, 4.3. So again, you know, the indigenous population is the one that carries the weight of this inequality. In terms of education, women do experience lower levels of education than men in nearly every level. As I said, in terms of poverty, close to 60% live in a poverty level with income less than $3.50. And that is highest in the indigenous population, where, again, anywhere between 75 and 80% are poor. In terms of access or coverage to health services, and I know that lately we've been hearing a lot about you know, number of health workers or number of beds for the population because of the pandemic. In Guatemala, we only have 13 health workers per 10,000 Guatemalans, whereas the WHO recommends that at least 23 health workers should exist for every 10,000 people. About 51% of women between 15 and 49 have access to family planning services. That means that half of them have absolutely no access. And 26% of the population have no basic health care services within 5 kilometers of Guatemala. Now you may be wondering, 5 kilometers, you can probably walk that in an hour, but that's not the reality for the women in our highlands. 5 kilometers can take anywhere between 2 or 3 hours for them to walk, or if they're carrying their children, it may even take that much, much longer. Close to 20% of basic drugs and supplies are not available in national hospitals. And that has become quite evident now with the pandemic. We knew that the healthcare system in Guatemala was broken before this virus crept into our lives. But it has been even more obvious now of how dysfunctional and broken that system has been for generations now. And once again, the population that gets the blunt of this is the rural, indigenous, and poor population. In terms of hunger, if you look at the Americas, Guatemala is the only country there highlighted in red. That means that we're the only country that will not achieve the Millennium Development Goal for hunger, that we didn't achieve that rather. And in terms of chronic malnutrition, once again, Guatemala in the Americas is the only one highlighted in red. 47% according to the latest survey, 47% of children under 5 are chronically malnourished. For sexual intercourse at first birth, the average age of first sexual intercourse for women is 18 and for men is 17. 8% of women aged 15 to 24 had the first intercourse before the age of 15. The average age of the first birth is 20. 21% of women between 15 and 19 have been pregnant. And the adolescent fertility rate is close to 120 pregnancies per 1,000 women ages 15 to 19, and that number is rising. In terms of the age of first intercourse, I'll just tell you something really quickly that happened to me before this phone call. A gentleman from the Ministerio Público, which is the agency in charge of investigating any crime, came into our office this morning. We had submitted some paperwork about a patient who was 14, and we had evidence that she had been raped. According to her, she was raped. We presented this paperwork back in November, and 8 months later today, this gentleman comes. That's just another explanation of another example rather of how broken the system is. If you have a 14-year-old girl who's being raped at home, and we are responsible to submit that paperwork to the investigative body, we would expect that to happen, that investigation to happen rather quickly, not 8 months later. And in terms of contraceptive use, 60% of women use a contraceptive method, of which 40% are not, rather 60% are using a contraceptive method and 40% are not using that. And of that, close to 50% use a modern form of contraception. Again, in the small box at the bottom, you can see the non-indigenous women, of course, that number is much, much higher. They do not use a contraceptive method, more than half. And that's another example of the discrepancies between indigenous and non-indigenous populations in our country that one must always be aware of. Let me jump quickly to another slide to show you our coverage area. This is WINGS 2020. The size of the country, for those who are not familiar with Guatemala, is similar to the size of Ohio or Tennessee, with about 17 million individuals. If you can see here what the red icon is, this is where our headquarters are. We have a clinic in the southeast part of the country in Reproductive, another clinic here in Guatemala City. And we serve 14 out of 22 departments via mobile units and satellite teams that Michelle will tell you more about in just a few minutes. And to finish my presentation in terms of our impact, This is since 2001, and here I just want to give a shout out to our founder. She's actually on the call right now. Her name is Sue Patterson, and she had this dream back in 1998. She got a phone call from someone she knew asking if she could donate some money that some women that this person knew had more than 7 children each. And a few months later, Sue had some money that some of her friends had donated, and in 2001 she officially established Wings, and I guess the rest is history. More than 300,000 individuals have been reached through sexual and reproductive health information and services. We have prevented more than 285,000 pregnancies, more than 1,600 infant deaths, and more than 100 maternal deaths. This is, of course, using an estimation with the Mary Stopes International Impact 2 model. And in terms of CYP, and for those of you who may not be familiar with the term couple of years of protection, let me just quickly read the definition. A CYP, or a couple of years of protection, is the estimated protection provided by contraceptive methods during a 1-year period based upon the volume of all contraceptive distributed to clients during that period. We only have data since 2011, but since then we have provided more than 220,000 CYPs. And there at the bottom, you can see an analysis. This is my MBA talking. I like to, see numbers and know numbers so that we can make better strategic decisions. Since then, we have been able to reduce our cost per CYP from $62.53 in 2014 to $16.89 in 2019. The global average is $12.50. For Latin America is $22, and for Guatemala that's $26. So I guess we're doing, quite all right. We had some projections for 2020. I think that's all gone out the window, but that's not to say that we will not continue doing everything we can to provide these services to all the individuals that we can. So with that, let me stop sharing my screen, and I will turn on the microphone over to Michelle.
Thank you, Rodrigo. So hello, I'm going to talk a little bit about the work that we used to do in Wings before COVID, and how we had to change, and we need to make a lot of changes. We actually are already changing just as the rest of the world, right? We are a team of about 50 Guatemalans, very passionate people, dreamers. We dream of a better Guatemala and a better world. And we really believe that we can reach our dreams, and we can help our people to reach their goals by reducing or making them able to decide what they want to do with their lives. As you saw in the video, we were used to provide contraception or family planning services, especially tubal ligations, vasectomies, IUDs, and hormonal implants through 3 mobile units, these beautiful trucks that were modified throughout half of the country. Usually they get outside on Monday and give services Monday all week long, and came back on Friday. So it's a very hard job for our team. It takes a lot of courage from them to leave their families, to leave their communities, and all because they loved what they do. These trucks have been modified to transport everything we need to settle up pop-up clinics. We actually have two types of pop-up clinics. In one of them, we provide LARCs, long-active reversible methods, IUDs, and hormonal implants. And in the other type of clinics, we provide surgeries, tubal ligations, and vasectomies. And in both types of clinics, we provide screening of cervical cancer. The long-acting reversible methods, IUD and hormonal implants, we can set up a clinic for those kind of clinics in almost every place, a house, a school, a community space, even a church sometimes. Even if it sounds incredible, we have performed certain IUDs and hormonal implants in churches. So things are changing. We have to start thinking that indigenous people or poor people don't need services or will not accept services. They are really open to receive services. They don't have access to them. So we have to be the first one to take out that thinking, that way of thinking of our heads. For surgeries, we prefer to look for safer places. We try to do it in hospitals so that we can provide the optimal conditions to avoid or to assure that we can handle any complications. So we provide surgical jornadas or surgical clinics in specific hospitals that we have already talked with, maybe once a month, 2 times every month, depending of the need of the community. But we want to really make up this confidence with the community. If we come every year, they don't believe in us. If we want to gain trust, we have to be persistent. So we have to be there every month or 2 times every month. We are very focused on quality of our services, starting from the constant training of our staff. You have no idea how difficult it is to train one of our nurses, because we take them like a very small child, a 5-year-old child, and we try to teach them everything so that we maintain some quality in all the country, in all our staff. From the training of the staff, from the medical audit, we're trying to perform medical audit in every member of the staff, especially the nurses and the doctors providing services, choosing the places where we perform the services, the quality of information that we provide, the quality of the medical supplies that we buy and use, the follow-up of process of the people, so we can find possible complications or complaints. We're very open, and we're trying to change that in our minds, that we need that feedback from our patients to change the things that we're not doing right. And a lot of examples in which we are trying to be different. That's our goal, to be the best thing that we can do, to bring the best service that we can give. I have a kind of mantra that I always say to my team that translated to English would sound something like, our services should always be given with love, with quality and warmth or care or love. So that has to make us be different. In some places, there are probably other services in which people can receive a specific method, but we always encourage the team that we have to be different. Maybe it's the same IUD, maybe not. Maybe our quality will be better, I hope so, that we provided with excellent quality. But we have to give that extra ingredient of love and heart. And I always tell them, please treat every woman and every person that comes for us like it's your mother. Because if you think it's your mother, you're gonna treat him or treat her with more patience and with more love. The feedback that we have received from some of our patients is spectacular sometimes. Actually reflects all these trainings that we've been giving our team. I've heard stories so very beautiful, such as a woman who have waited for months for us to come. She had access to other providers, but no, she wanted to wait for us because her sister had a surgery with us, and she told her that we were so nice and we gave her a soup and we were so lovely. And that I think we should be very proud of it. Actually, I am very proud of my team because I think we are doing things different. with this methodology, we were able to provide services to even 20 or 25 women in one day. This is because we treat them as outpatients. They come, so a normal day will be the patient come that day in the morning, receive the surgery, maybe 10, 15 minutes of the surgery. Then we watch her for an hour just to see if everything is okay. And then she goes to her house. We provide her something to eat before she leaves, and she leaves the same day. This allows women to receive their tubal ligation and be in their home the same day. That is maybe the biggest barrier why women don't go to national public hospitals, because they would be hospitalized maybe 1 or 2 days, and they are not able to leave their families alone for 1 or 2 nights, or maybe they are afraid. So this is a big opportunity for women to have access to the tubal ligations, but be back in their house the same day. But at the same time, this beautiful way of working, of providing services to a lot of women in one day, because it's local anesthesia and it's a very quick procedure, is also the biggest barrier for us now that COVID-19 is doing all his work. So our maybe our biggest strength now is one of our biggest barriers, because we won't be able to put 20 or 25 women in one space, in one small space, for several months. As well, we won't be able to handle big groups of people where we're providing informational talks and promotion activities at the community level. So we are struggling with a lot of we're suffering a little bit, but this is pushing us and making us find other ways to work and to provide the services that people are needing. The other thing is that tubal ligations and vasectomies are not urgent procedures. They're not an emergency. So if you have appendicitis, of course, you have to go to the hospital now and receive an appendicectomy. But a tubal ligation and a vasectomy is not an emergency. If someone has a complication or anything goes wrong, whatever, the hospitals in Guatemala right now are absolutely full with patients with COVID. So we don't want to risk patients to a virus that can kill them. And that brings another conversation to the table and another problem for us. So let's be honest, family planning or contraception is a basic service, especially considering populations with high risk of sexual and domestic violence, as Guatemala and a lot of places in the world. So we can't stop. We need to continue providing services, but we have to be very honest that it's difficult to get to the places, difficult to get the patients to come for us. As the rest of the world, we need to provide our services to help our men and women to receive what they decide, what they need to achieve their reproductive rights, not or goals, not what we think, because that's something very paternalistic that we sometimes do, that, oh, I think this woman should receive a tubal ligation because she has too many kids. No, that's not the point of view that we have. We think that women, maybe I think she should not have more kids, but my responsibility and my job is to tell her what can happen to her if she had more kids, what can happen to her children if she had more kids. So my job and the job of my staff, my people, is to give information and to make men and women, to make them free to decide what is better for their lives. So now we need to add something to that equation. Do you remember I said my mantra is with love, with care, and with quality? Now we have to add something else, that is safety. Of course, we used to work with safety as we know it, normal medical safety, regular, that we've already trained them. But now we have to talk about safety related to COVID, that it's it's a huge, big deal. And finally, first of all, we have been working, so we have to provide services. How can we provide them in the safest way possible for our staff and for the population that we are serving? First of all, we have been working in safety protocols based on international and national guidelines, and providing these trainings to our staff. That has been it has been a struggle, because you have to think that most of our staff, they live in communities with very bad signal, so it has been difficult, but we have done it extremely better than what I thought at the beginning. But I have to say, it is working, especially with our youth program. We have a youth program in which we train youth leaders or youth to provide counseling, to provide information to their peers, and it's working perfectly in via Facebook, WhatsApp. So youth have this this quality of using better technology that I can. So now I will share with you some of the changes that we have to do in our service provision, and that we are already starting to make these changes. Now we are focusing, our focus is in LARCs, IUDs, hormonal implants, because we know that vasectomies and surgeries in women tubal ligations brings us a lot of complications and a lot of different things that we have to be sure before we start surgeries again. We think that we won't be able to provide tubal ligations in a while, and we will decide the best moments to do it depending on several circumstances that we have to be evaluating. With vasectomies, it's a little different, because vasectomies allows us to have less patients in a small place, and to ask them to come one patient at 9, another at 10, another at 11. With women, we cannot do that. So it's a little different. We need to change something in our vasectomy technique that we have already talked about. It's still safe and it's still a good technique, but the smoke that we were producing can be infected with the virus. So we're changing this little thing in our technique. We're providing personal protection equipment to all of our field staff. The mascarilla, the things, we're trying to give them everything they need. And of course, that's expensive. That's very, very expensive, and sometimes difficult to get this equipment for obvious reasons. All the world is buying equipment, so we sometimes have some difficulty to get it. We are giving almost all the counseling that we can via phone call, WhatsApp, Facebook. For us, Facebook is extremely useful. We're trying to give and receive as much information as we can by phone to reduce the time on a face-to-face interaction during the services in the clinics. This has been working in Antigua, in our main clinic. Now we are going to start doing it in the rest of the country. So a big work to do in front of us. The virus forced us to use technology. Maybe some of us don't like that much technology, or we didn't want it that much, but the virus helped and it's making us use the technology. We're finally doing changes that we've been talking for years. For example, we implemented something that we've been talking, the medical record, electronic medical record. So for years we were talking, what if we do this? But it never got real until now. So thank you, COVID. We started with our main clinic in Antigua, and it's working beautiful. So now we're buying the rest of the equipment to give computers and tablets to the rest of the team. And we hope that this change is going to help us protect our team, so that the interaction with the patient is going to be shortest. We're also trying to migrate to non-present activities of our promotional team, because these guys rock. These guys are the heroes. Are the promotional team is there are people walking and going through the country, finding patients or possible patients. They give counselings, they give community talks, and they bring patients finally to our services. We won't be able to give services if we don't have patients that come. But to do their job, they have to go sometimes house by house, or they organize talks in the community. But now with the COVID pandemic, we cannot do that. So they are working on new ways to provide this information. They're starting to use radio, local cable, WhatsApp, and other electronic platforms. And again, Facebook, thank you, Facebook. It's maybe our biggest electronic way of communicating. A lot of patients write to us via Messenger in Facebook. So it's our main platform, and this virus is making us rich and make us change the way we provide services, the way we provide information, education, and how we can reach to these patients, especially in the rural areas. So from my end, that is it. I don't know, Rodrigo, if you want to add something, or we can go to questions.
Yeah, thank you so much, both of you, for that wonderful presentation. Rodrigo, if you don't have anything to add, we can go into Q&A, but I just want to make sure beforehand. Good?
No, all good.
Great. Well, we've got a lot of really interesting submissions here, so we're going to try to get through as many as possible, but we'll just have to see how long all of this takes. So the first question is looking at religious barriers. And I know, Michelle, you had talked a little bit about the need not to assume that people just don't want access to contraceptives or healthcare or reproductive health, and that in fact there's a huge need. But I think the presumption also in this particular region is that there's a really pervasive religious influence that serves as a barrier to access to contraceptives. So the first question is, do you address these religious barriers in reproductive rights? And if so, then what is the best method to sort of counter the religious and other arguments against contraceptives, and more broadly, like birth control and women's autonomy?
Mm-hmm. Well, actually, we don't directly program advocacy strategies targeted to religious barriers. We don't see them as enemies. We see them as allies sometimes. In most of the communities that we serve, where we work, I will say everybody has a religion. Most of the time Catholic or evangelical Christian church. But we try to be very respectful. Actually, we have had very good experiences. We try to maintain very good communications with community stakeholders or leaders in the community. And we try to always find local partners that helps us in these interactions with religious leaders. We always have a message, and I always say to the staff a magical word, that is respect. If we are respectful, they will respect us too. It's interesting because sometimes we have even got involved with local churches, and we have done pop-up clinics in facilities of the church. So they are, a lot of them, they are able, they are open to family planning, because they understand that this is going to help with poverty and maternal death and child death and malnourished, that word. What they're not able or to be open, or they will never, ever, ever accept, is abortion. So sometimes they think it's the same thing, abortion and family planning methods. So a lot of our message and in our counseling is, this is not, you will not have an abortion if this fails. If you're using something and it fails, you will not have an abortion. You probably go with your pregnancy and your child is going to be okay. So we have to be smart enough to use the right words. But actually, the first time we went to Totonicapán, a very indigenous region, everybody told me, you're crazy, there's not gonna be man for vasectomy, they're very religious, men will not accept that ever, ever. And our biggest surprise was that that day, seven men came for a vasectomy. So sometimes we who have privilege, we think that people won't accept, that we have to convince them, and that's not true. That's the first thing we have to take out of our minds. And at a personal level, I'm a believer. I believe in God. I'm not religious, but I'm a believer. So I understand, as a Guatemalan, I understand what they feel, what they want. But I also understand the need, and they want healthy children and healthy women, and they don't want the women to die giving birth. So I think that things are changing.
Yeah, that's amazing. Thank you. I think also there's kind of, it's nice to hear you say that there's a pretty wide and broad understanding of accurate sort of medicine and science regarding family planning. Another question was, what are some of the biggest sort of misconceptions about reproductive health care? You mentioned the conflation with family planning and abortion. Are there other ones that are sort of pervasive in Guatemala or endemic to the country that you guys have had to address or overcome?
Mm-hmm. Can you repeat that last part? Sorry, I didn't.
Just talking about some of the misconceptions about what family planning is and the effect that it may have on your body in terms of your overall health or whatever.
Yeah.
Let me take that one. So there are a lot of myths around family planning and contraceptive methods. One clear example is IUDs. There's so many myths around that, and they come from a generation or two back. So we do have to take a lot of effort in debunking this myths and talking about the benefits and of course the side effects. We're truly open and honest, and that certainly helps the conversation and to educate our users.
For example, I like to use an example, and I encourage our team to use a personal, very honest example. In my case, I say to the people, imagine if I have 1 pound of beans, and in my kitchen we are 3 people. Oh, we're gonna have a very good meal. But what happens if we are 10 in my house? We're gonna have a very small portion. And I have had a lot of indigenous women that have told me, oh doctor, you're right. God doesn't want me to bring children to starve to death. You're right. I don't want to have more children because I understand. So if we use the right words, people are able to decide by themselves.
Thank you. So another question is looking at the sort of demographics of Guatemala. There's a very high indigenous population. I think over, is it 40 or 45% of the entire country is indigenous. And within that, there's many different factions and groups who identify differently and who use different languages and so on. So I imagine that must be really difficult to approach in terms of access to care and, you know, sort of using the correct approach for each group. So what barriers do you see there, or has that been something that has been fairly easy? How do you approach the very diverse population in Guatemala?
So we have 22 languages. It's our dream will be to hire 22 different people from different areas, but that's not a reality. We try to find people from different regions that speak at least one or two indigenous languages. But we have to ally with somebody. So every time we go to a community, we try to find someone that translates for us, because people need to hear in their maternal language the information that we bring. For example, Zenaida is a beautiful nurse of us. She works in the lake in Solola, and we encourage her to go to the services with her indigenous clothes and only wear something up encima, what do you say?
Above.
And that gives her a lot of credibility in the activity, because women see her and say, oh, she understands me, she knows what I mean, she knows what I believe. So we try to do it in every place we go. It's not a reality that we can do it everywhere, but again, the word respect, it's not the same way they react in this in Escuintla, where they don't care opening and taking out the clothes, that in Totonicapan, then they are very shy. So we have to be very respectful for their specific community circumstances.
Yes, there's another question just about the sort of mistrust amongst Indigenous people, rightly so, of Western medicine and sort of modern medical approaches. So it's great to hear that you guys sort of contract with and hire people who have connections to the communities that you serve. I think that that's a really important part of your approach. Thank you. So another question is asking about the sort of impact that the pandemic has had and the restrictions that have been implemented as by Guatemala in order to control, sorry, can you not hear me? To control the spread of COVID-19. And so the question is asking about the sort of indirect effects that COVID-19 will have on Guatemala as a country, and what are some of the predictions for some of the biggest issues that Guatemala will be facing in the coming year, even aside from coronavirus?
That's the million-dollar question. I think that's the most difficult and yet important question that we ask ourselves every single week. And I think that the key word here is predict. You know, a lot of what we're doing and what we're deciding, not really decisions, but assumptions that are based on incomplete data. There's just so much coming to us from different sources that we need to be very flexible and nimble. But the question is about, you know, the impact that COVID-19 or the repercussions in Guatemala. And I think the biggest three will be health, you know, and I'm not talking just about reproductive health, but health in general. The health system in Guatemala was already broken, as I mentioned, and now you can really see that it's decimated and shattered into pieces. 70% of our population is working informally or part of the informal workforce. They don't have a cushion, you know, to go to that's going to soften the fall. So they're going to be quite affected, you know, by the lack of health services that are available. They'll be affected by the economic repercussions, of course. Guatemala is considered a middle income country. Again, tyranny of the averages, but that's what we are considered. There is not a very large, but you know, a significant portion of the population that's middle class. I think we will see a lot of people in that bracket recede to poverty levels. I think the world over will see that. And lastly, I worry about the education, especially of girls. I think girls have been taken out of school and they will not be brought back to school. And that's just, I think it's going to set us back, years and years as a society. So I worry that those three will be, the biggest repercussions of this, besides, of course, from COVID.
Thank you. So another question is looking at just the population growth within Guatemala as a whole, both historically and presently, and then that connection to climate change. I know that Guatemala is one of the most climate vulnerable countries on Earth. And with that, one of the questions is asking how population plays into that in terms of increasing climate vulnerability, or making it harder to adapt, or what have you.
No, yeah, I mean, I certainly feel, some days I feel like it's already too late for our planet and for Guatemala. I do have hope in the newer generations, and as I have hope, for the individuals in this call, those of us who consider ourselves progressive and are aware of our surroundings, whichever the reason is for supporting sexual and reproductive health and rights may be, we have to understand that the impact in the environment will be positive. Guatemala has, as you well mentioned, has been included in the list of top 10 countries in the world most at risk of environmental and climate change. But I don't think that information has permeated enough in our society that people are really worried about that. Some of us, who are lucky enough, as Michelle said, privileged enough to read and follow, this information, are aware of it. But, some of you, I imagine that some of you have read the book Drawdown. And if you have not, it's this really wonderful book that I highly recommend. There you can see that both family planning and educating girls together make up the #1 activity to help reverse global warming. In their update, which I believe came out late last year or early this year, they lumped together health and education, and it's now the second most important thing that we can do. So I would just say, whatever it is that we're doing, let's keep on that. Let's continue supporting access to reproductive health services and rights, because if you worry about the environment, it will have a positive impact on it.
Thank you. That's a wonderful answer. Yeah, Drawdown is something that we as an organization use and reference quite frequently, and I think it's really helpful in kind of making the connection between reproductive health and climate change and population. So kind of focusing back in on family planning in Guatemala, one question is asking about the influence that men and boys have had within the family planning sphere. So I guess there was mention that men and husbands are sometimes sexist and for that reason want to have many children. And if that's true, what is being done to educate them and to include men in the family planning process to change their views about the benefits of family planning and having smaller families? And I guess with that, we can also kind of ask about the evolution of family planning, perceptions about family planning in Guatemala, and how they've changed over time to include men, and if there's an ideal family size at this time for the country.
Oh, that's a lot of questions into one, but I'll try to. And Michelle, please jump in if you think I'm not getting all of it. Certainly, WINGS, we include men and adolescent boys in our programs. They're not the biggest beneficiaries of our programs. They account for about 2% of the people that we serve directly with contraceptive methods. And nonetheless, vasectomies have been increasing for us, at least in terms of percentage of total services. This past year, vasectomies accounted for 13% of our surgeries. This year, we have projected about 27% of our total surgeries. So we certainly do talk about men being responsible for this as well. And like Michelle said, we have, we're surprised sometimes, like the story in Totonipacapan, where seven men came for vasectomy. So that's certainly true. Perhaps the program in which we address more this issue is our youth leadership program. We have on any given year a cohort of 50 youth leaders, half of them being boys and half being girls, ages 13 to 19. And that's probably where we talk the most about this issue. And we have seen, some positive results and boys, changing their perceptions and going back to their homes and talking to their families and talking to their brothers and, and friends and parents about what it is to be a real man. It's not about being, machista and sexist, but it's about, being a partner, being part of this whole process. Why is it that men, resist contraception? It's our culture. The Mayan culture is quite conservative and sexist. It has been like that for generations. And so, a lot of different variables come into play that I'm sure those of you who have worked in other parts of the world, may have the same experiences as us. But it's certainly, just one example is that vasectomies are not at the level of tubal ligations. That's just an example of where the differences are. I hope I was able to answer those questions.
Yeah, that was perfect. You did a really great job. I gave you 3 in 1 there. You did it perfectly. So it's about 12:06 right now. So we're running a little bit over. I still see that most people are on the call, so we can go ahead with 1 or maybe 2 more questions. So I think that just generally we've heard a lot about what you guys do and how you've been affected by COVID-19. I guess what I'm kind of wondering is what your goals are for this particular year, given all of the massive structural changes that have been put in place as a consequence of the pandemic and just, Guatemala politics as a whole. Where do you guys see yourself in this upcoming year in terms of the goals you've set for yourself, and how do they differ from last year? And where are you going from here?
Where are we going? Wings, and certainly, the world and Wings was not ready for this. It's been a challenge, just getting enough PPE for all our staff, getting non-contact thermometers, things like that may seem trivial in other parts of the world, certainly in the US, have been a complete challenge here. Just an example, there's no N95 masks out in the market. So we're going for other options. What I can assure you is that we will continue trying our very best. I think, I know we just a couple of weeks ago, we had a survey for our employees. It was anonymous. It was really about commitment to the mission and commitment to the institution. And 74% are fully 100% committed, 20% more are committed. So that just gives you 94% of our staff that are committed to the mission and to the vision that we have. This year will certainly be difficult, and who knows what the next year will be. Michelle just talked about, why we can't offer tubal ligations. There are so many issues out there. Just this morning, the WHO, kind of reversing itself, said that they now know that droplets in the air can contain the virus. We offer our surgeries or tubal ligations in tiny rooms with no ventilation. The technique that we use, in which we insufflate the pelvic cavity of the patient, when we release the laparoscope, that gas goes out into the atmosphere. So there's a higher risk if the virus is present in that gas, for our staff. And now that we know, because the WHO said so, that in the air there's presence of the virus, And the best thing you can do is not have a lot of people in cramped rooms with no ventilation. That, you know, we're not able to work around that. It's just impossible. And so there's certainly many challenges, but we have, you know, the best attitude, and we will continue doing the very best we can. I completely 100% believe in our staff and their commitment. And that's all I can say is we're committed to doing our very best.
Mhm.
That's great. Thank you so much. I think we're going to wrap up here. I think that the presentation was wonderful and a really perfect explanation of the very important and impactful work you guys are doing in the reproductive health sphere in Guatemala and elsewhere. So thank you so much. Again, we're very proud to partner with you guys. Just before we leave, I just wanted to make sure that you guys can take an opportunity to tell people who are on the call how to get in contact with you should they want more information on the organization or to get involved in any way.
Yeah, thank you so much to everyone. And I see so many familiar names. I would like to have, you know, thank everyone individually, but I don't think that's appropriate. But thank you so much for the opportunity. As the executive director of Wings, I'll just say, you know, it's really an honor to partner with Population Connection. And for me personally, it's an honor to be a member of the board. If you guys want to get in contact with us, please go to our website, wingsguate.org. You can reach us via email. The general email is info@wingsguatemala.org. I just shared my email, which is my name and last name, Rodrigo Barillas @wingsguate.org. And just, you know, please look us up on social media as well. So you can find us there. So thank you. Michelle, would you like to say?
Yeah, I'm writing those things, but yeah, please feel free to reach us if we can help you in something or you need more information. We're very able to talk whenever you want. Yeah. Wings.
Great.
Yeah,
Well,
let me just write our website. There it is for everyone, wingsguate.org.
perfect. And perhaps you can send a follow-up email for everyone who registered with that information as well.
Thank you, Hannah. And I saw some of the questions and some people who are hoping to get, you know, the presentation or the video. You guys have that. You, Hannah, have that. Please, you know, feel free to share it with everyone. We appreciate it.
Will do. Okay, thank you everyone for attending. We will talk to you very soon and expect a follow-up email. So thanks again, Michelle and Rodrigo.
Thank you so much.
Bye. Thank you.
Bye.
Bye.